you, sir, for the kind invitation, and very good afternoon to all of you. I would be talking to you about the art of PVD induction, which has become an integral part of any vitrectomy procedure nowadays, and for different conditions there are different variations on how we approach it and do this part. We all know that the vitreous is attached very comfortably all around at 4 or 5 different places, and then there are pathologic attachments as well which come into play, and then we need to take care of all those areas while we are doing this procedure. So typically what we approach it as nowadays is to stain it with triamcinolone in any case of a macular hole or a pucker, or any case that we are trying to use it. We need to stain it with triamcinolone to get a better visibility. Otherwise we are not sure how well you are seeing it or grasping it, and once you have stained it, you know exactly how to grasp it within the port of the cutter or whatever instrument you are using, and then pull at it to confirm that the hyaloid is eliminated from there. So this is for a typical hole. Now when you come to a vitreomacular traction, there is a slight variation as to how you would do it. You would stain the same way, and as you see, you're seeing the halos of the triamcinolone stain attached hyaloid on the macula and on the disc. But here you don't want to pull at it totally, because when you pull at it totally, you might pinch a small hole right at the fovea, because of the adhesion is pathological here and is not the standard vitreomacular attachments that one sees in this. So now we go on to a high mag lens and try and see and segment this whole connection from the rest of the vitreous, so that all you have is a small skirt of attached vitreous left on the foveal area. I think there's a lot of disturbance in the connection. I don't know if they can solve it. Is it? Anyways, so here how we approach it is that you segment the small skirt and then remove it by removing the ILM rather than trying to pinch and remove it totally, and you can see that it comes off very comfortably along with the scaffold of the ILM, because that's where the hyaloid is attached in the first place. Similarly, if there is a thick epiretinal membrane and your first aim during the surgery is to go in and remove the hyaloid, so we stain it and in the same way approach it by high suction over the triamcinolone in stained area. But here, as you can see, that as we are moving the vitreous, pulling the vitreous, the membrane, which is well formed, also tends to show a movement. So gently we grab the vitreous in such a way that we carefully remove the membrane along with the same process, and you don't need to separately go in and remove it. But of course you need to keep that area under very close watch, because the last thing you need is a rip in the retina if the adhesion is too strong. So you can see that the whole membrane has come off totally in this situation. Now if there's a vascular entity, you might have proliferations and some vascular adhesions. You need to be careful, because it can resort to a lot of bleeding, because all the vasculature is coming from the retina and the choroid and is coming in and attaching as a scaffold, forming proliferation. So here you need to be a bit gentler, keep assessing. Sometimes the adhesions are strong and you can rip a break or a tear there, so you don't want to do that. So if you feel that it's coming off easily without causing any major traction, then you can remove it in toto. You can see the mild petechial hemorrhages seen below, or the disc where probably the scaffold of the new vessels was connected starts to bleed a bit. So you raise the pressure, control it, and if required you need to use a diathermy to control it. So vascular conditions would behave differently. The large subhyaloid hemorrhage over the foveal area for which we are operating again needs a similar approach. You first remove the core which is there, and then try and find a plane to remove the hyaloid adhesion, because the blood is usually trapped beneath that. Now we all know that in some of these vascular situations over time the vitreous tends to split and has two components. So here what you're seeing is a whole component of vitreous coming off, and in spite of it moving, the blood is still trapped, and one gets confused at times that you feel that the hyaloid is already removed from there, and why is the blood not coming off? But that's because you probably remove a small cortical portion of the posterior attachment, and the main chunk is still behind. So you will find these variations in different cases, and every case will not have exactly the same way the hyaloid would come off. So here now we approach the hyaloid, which is the true hyaloid, where you can see that as soon as it moves, you will see the whole way the blood below behaves, and the whole sheet comes off, and then you can, of course, once it's removed, you can very easily eat it up and clean it up from the fundus surface. So and it's usually in a liquefied state. All you need is a good suction at that stage, and the cutter can be very, very easily taken there, and by a painting movement you can remove most of these adhesions, and whatever is bleeding because of the scaffold, the proliferations, one can raise pressure and then go back and diathermize those areas to clear that. So in vascular cases, one needs to have an alternative way of approaching that. Young patients with foreign bodies inside, before you approach the foreign body, it's always a good idea to remove the hyaloid, which you can see, because these cases are notorious for going into PVR changes, because we are very happy removing the foreign body. You just go in and slightly loosen it, take a magnet, remove it, but then what you leave behind is the whole vitreous, and within a month the patient would come back to you with a detachment or already a PVR change taking place in that. So here you can see that as we remove the hyaloid, the foreign body loosens up, and then later on you can remove it and take care of whatever damage it's done eventually below. Now comes the more important aspect, which is where the attached mobile retina is there. All the other cases that we looked at were attached retina situations where we were removing. Now, once the retina is mobile, the situation changes, because whenever you pull or tug at any tissue, the retina also moves along, and it can create more problems. So here, once again, the triamcinolone is very useful, because it constantly gives you a view of where these attachments are there, and you can approach it without trying to create tears in the retinal surface. So you can see in young patients, it's sometimes very tautly adherent and is difficult, but with some persistence you can try to form planes inside. Like we found a gap here, then use the cutter, make a slight opening here so that there's a loosening of the attachment, then again go use the suction and trap some more vitreous and remove it. So slowly, with some effort, you can gently remove that whole vitreous adhesion, and then you can approach and take care of the rest of the detachment, and this would lower the chances of recurrences of PVR and other problems in these situations. This is again a small clip in a detached retina with a puckering in the center, where again our first approach is to remove the vitreous in that particular area, and as you see that we are applying high vacuum after the grasp is seen of the vitreous, and there is a puckering in the macular area, and as we pull at this tissue, you will see that the pucker also comes along. So a lot of these well-formed macular puckers can actually come out with hyaloid. We've all seen cases of spontaneous removal of the puckers in patients when they come for follow-ups at times. So even on table you will see these formations. But of course we know that whenever we create a hyaloid detachment, we are actually doing something pathological by itself removing, because we are removing a tissue forcibly, and it has its own consequences in some cases. A simple case of macular hole where we have just removed the hyaloid PVD creation, and when you screen the inferior periphery, you might see these small collections of fluid or operculums, and this is something that we all dread to see, because it was a simple, straightforward case, and now you are seeing small breaks, and these are potential for a patient coming back to you with a detachment. So make sure you skin the inferior periphery in such cases. Carefully look at them. If you have the slightest suspicion, like we saw in this case, make sure you laser barrage that whole area, and of course the vitreous needs to be removed from there, so that the chances of a detachment become less. Macular holes are notorious for these inferior breaks which can form. This is also immediately after the PVD creation in a macro hole, and you can see that we've ripped a whole tear in this area, which is ragged. Now this is a pathological adhesion. It's like a thinned out area which had a vitreous adhesion and has given way just because we pulled at it. So sometimes you might have these rare cases where the very mid-peripherally you might have tears or rips happening because of lesions which are pre-existing. So one has to make sure that you clear the vitreous, laser that whole area properly, and then of course take care of the hole and the gas, whatever one wants to do in such cases. So PVD creation also needs to be checked after you finish it, so that you don't create breaks. But of course you do have, once for pathologies like holes and puckers, there are very gratifying results if the whole procedure is done very well. Vitreomacular tractions, which because of the OCTs have become easily diagnosable now, and I think a lot of them, once they are symptomatic, we go ahead and treat them and you can get fairly good results. Although very soon we might have a